Well, my task is to just give you some introduction to principles of how we're going to start doing this, and the other speakers are going to take it a step further. So I'm going to give you the basic nomenclature. What is the language that we use when we talk about limb alignment? So all this is really derived from a book that we published about 10 or 12 years ago. But if you don't read Chinese, don't worry, because it's recently been translated into English, so you can get the English version as well. So let's start with some definitions. Where are we? What is normal limb alignment? Normal limb alignment is when the hip, knee, and ankle line up. Well, if you look really closely at this diagram, you'll say, wait, Dr. Herzenberg, the line doesn't really pass through the center of the knee. And if you look at a bunch of normal people, it tends to pass a little bit medial. But when we do planning and we do corrections, we aim for the center of the knee. That's what we consider to be nirvana. If you look at population averages, the mechanical axis passes about a centimeter medial, up to 8-9 millimeters medial. But we did another study. It's never been published, but we looked at 60 and older adults who didn't have arthritis of the knee. In other words, they made it their whole life to age 60 without arthritis. And their mechanical axes tended to be a little bit closer to the center. So while many of you in the room may be perfectly normal, happy, have normal knees, can run a marathon, but maybe you're a little bit bow-legged. And what you're going to be like 40 years from now or 50 years from now is a different story. So what's ideal? Let's consider ideal to be, we'll all agree on this, that ideal is the hip, knee, and ankle fall in a straight line, go through the center. So that's the mechanical axis of the entire limb, from the hip to the ankle. We can also look individually at the bones. So we can look at the femur and the tibia. So the definition of mechanical axis is a line that goes from the center of a joint to the center of the joint. So in the femur, it goes from the center of the ball of the femur to the center of the knee joint. That's the mechanical axis of the femur. And the tibia goes from the center of the knee to the center of the ankle. Now immediately you'll see a difference here, because in the femur, that red line, the mechanical axis, part of it's outside the bone, part of it's inside the bone, because of the funny nature of the femur with the offset neck. But that is the definition of femoral mechanical axis, center of joint to center of joint. And you can draw it on the sagittal view too. You can draw from a lateral, from the center of the hip to the center of the knee. We don't use that as much. Then there's another concept called anatomic axis. And the anatomic axis is basically the diaphysis of the bone. It's where your intramedullary nail would go. So on the femur, it's straight shot down the shaft. On the tibia, also straight shot down the shaft. So on the tibia, the mechanical axis and the anatomic axis are basically the same. Center joint, straight down the shaft, it's the same line. On the femur, there are two totally different lines, because now the red line is totally contained within the confines of the bone, as opposed to here, where it was half in, half out. So there is about a 6-degree difference between anatomic and mechanical axis in the femur. But in the tibia, it's one line. On the sagittal view, the femur, for a lot of us, has about a 5 or 10-degree bow. Some people have very straight femurs, but most people have a slight bow. So when you look at the way femoral nails are made, they're usually made to have a slight bow down them, the trauma nails. So that's the mid-diaphyseal line for the anatomic axis. The next concept is that we need to understand is the concept of joint orientation. So we have to have a system to describe the hip, the knee, and the ankle. If we're going to start to talk about a joint line that's inclined, a Blount's disease, or varus hip deformity, we have to all agree on nomenclature for defining how we're describing the joint. So for the joint orientation line of the knee, on the AP and lateral view, it's pretty straightforward. You draw a line from the top of the tibial plateaus. On the sagittal view, same thing. From front to back, you draw a straight line. That's the knee joint axis. On the distal femur, it's even easier. You just take the tips of the femoral condyles on the AP view. On the lateral view, it's a little bit trickier because you don't see the knee as easily on the lateral as you do in the tibia, the distal femur rather. So on a child, you can pretty much go from tip of growth plate to tip of growth plate. On the adult, you can see on the x-ray the edge of the joint from front to back. That's a little bit of a soft line, but these are the joint orientation lines for AP and lateral femur, and we just did AP and lateral tibia. So now what's left is the distal tibia. It's the distal tibial plafond line. You draw 2 points connecting them on the AP view, and on the lateral view from the posterior calicus to the anterior calicus. So it's very straightforward to draw these lines on the knee and the ankle. These are the joint orientation lines. Now what about the hip? How do you draw? The hip is a circle, so how do you draw a line? You go tangent to it. What do you do? The convention that we propose is drawing a line from the center of the hip to the tip of the trochanter. This works for adults because adults are ossified, but in a child that's 6, 7 years old, 5, 6 years old, you don't have ossification of the tip of the trochanter yet. And so that line is not as valid in a child. But for an adult, that's a pretty valid line. And so we're proposing this discrete line from tip of troch to center of head as being a representation of the orientation of the hip joint. You're going to have to wrap your head around that gradually. Because we're proposing a straight line to represent a ball. When you put it all together, you get a diagram like this. And we keep this diagram in our clinic on the wall. Yesterday I talked about the multiplier app. It's in our multiplier app under additional resources, so if you forget these numbers, I pretty much reached the point excuse me, where I kind of know these by heart. But as a beginner, you may not, and so it's useful to keep a little card in your pocket or a diagram on the wall. So the important numbers that you're going to use the most are the numbers of the knee. So when we take the mechanical axis of the femur and you see how does that intersect the knee joint. The knee joint is typically not perpendicular. It's a little canted. So you can measure this on the medial side or on the lateral side. Excuse me. It's up to you. But we propose in this book 12 years ago, and now it's pretty much become convention, and you see in the literature people are using this terminology. We propose that you describe the femur on the lateral side, and we call it the lateral distal femoral angle, and the tibia knee joint axis you describe on the medial side. Now, why do we do it that way? The answer is because we like numbers that are less than 100. And so if the average number for an LDFA is 88 degrees, oh, thank you very much. Thanks. If the average number is 88 degrees, it would correspond to 92. So if we're shooting for numbers that are less than right angle, it's just easier to remember. You do it that way. If one of you wants to go out and invent your own system, you can define this on the medial angle versus the lateral angle. It's up to you. But this is already in the literature, and you see articles in JBJS where they quote the LDFA, MPTA, and so forth. So the numbers are listed in the ranges. So the average for an LDFA is 87 or 88 degrees. LDFA standing for lateral distal femoral angle. MPTA, the medial proximal tibial angle. And then you can extend that to the ankle. We go back to the lateral side, and we talk about the lateral distal tibial angle. And up to the top, remember that we drew that orientation line of the femur from the tip of troch to center of head. How does that relate to the mechanical axis of the femur? We call that the lateral proximal femoral angle. So all this is just sort of describing normal anatomy. If I took an x-ray of any one of you in the room, I could draw these lines, and pretty much all of you would fall into, I haven't asked you all to stand up, but all of you would probably fall into these numbers, and your LDFAs would be between 85 and 90, your MPTAs would be between 85 and 90, and your LDTAs between 86 and 92. You can quibble about a degree here or there, but pretty much people fall into this grade. So this is basic nomenclature. The last one up there is the JLCA, stands for Joint Lateral Convergence Angle. And what that is referring to is some patients have an unstable knee, and so they'll have laxity in their knee joint, and so the distal femoral line, proximal tibial line may not be parallel. So if you've got someone with a big ruptured lateral collateral ligament or medial collateral ligament and they stand, their joint books open, this is a way of measuring that and putting it down. But normally it's less than 2 degrees. You can also measure anatomic angles. This is all mechanical angles, right? From the center of the head to the center of the knee, from the center of the knee to the center of the tibia. But if you draw the anatomic lines, which we sometimes do, especially when we're doing anatomic planning for putting in an IM rod, the numbers are a little bit different. Because where are they different? They're different in the femur. So in the femur, the number that's different is the anatomic lateral distal femoral angle, the LDFA. Instead of being 87 degrees or 88 degrees, you got to knock 6 degrees off because of the difference between anatomic and mechanical, and it becomes 81 degrees. So the normal anatomic LDFA is 81 versus the normal mechanical LDFA 88 or 87. The other number that changes is the number at the top, because now if we look at our joint orientation line, the anatomic axis line intersects it a little bit differently than the mechanical. And so we measure this on the medial side, and we call it the medial proximal femoral angle, and measures 84. That contrasts with the 90-degree LPFA at the top. So depending on whether you're measuring to a mechanical or anatomic, and when we're talking with each other, we have to make sure we're talking the same language. So the little small m in front of the LDFA refers to mechanical. This is a mechanical LDFA. The next slide, I'm going to show you the little a before LDFA. That refers to anatomic LDFA. And you can't mix and match these. You can't measure proximally with a mechanical line and distally with an anatomic line. You've got to use one system or the other. On the sagittal view, we draw anatomic lines. And there's a couple of interesting points. If you look at the intersection on the tibia, for example, between the anatomic mid-diaphyseal line and the joint orientation line, it doesn't intersect in the middle of the knee on the sagittal view. It intersects about a fifth of the way back. That's just normal anatomy. That's the way it is. You can't change that. So we call that the posterior proximal tibial angle. It's usually about 10 degrees down, or in this case 81, 9 degrees down. That's the normal posterior slope that you have in your tibia. And then if you draw the distal femoral joint orientation line, which we did from the front of the knee to the back of the knee, and you measure that relative to the anatomic axis, it's also tilted. It's a little bit less than 90, here, typically 83 degrees. So when we start to describe deformities, if people fall outside of this range, then we know that they have a deformity. So all I've talked to you up till now is just what's normal. And I should mention also distally the anatomic anterior distal tibial angle. That describes whether or not your ankle joint is canted upright in the normal 10-degree position, or if it's vertical or plantar based. So this is all normal anatomy, and everyone should have these numbers. I mentioned the joint lateral convergence angle. So if you have more than, say, 2 degrees, then you're dealing with a joint instability problem. I mean, you could have totally normal numbers, 87 degree. In this example, we have an 87-degree femur. We have an abnormal tibia. This is an abnormal tibia. Let's say it wasn't. Let's say it's normal, 87 degrees. But it's clearly a varus leg. Where is the varus coming from? It's coming from the ruptured lateral collateral ligament, the laxity there. So sometimes deformities are not caused by bony problems, they're caused by soft tissue alignment problems. Okay, so we talked about this, about the normal mechanical axis of the limb. When we do our planning, we'll shoot for right down the center of the knee, not, even though you'll say, well, this is kind of normal, right? This is what big population studies showed. But we don't shoot for that. I think the real system should be to go down the center of the knee. So here's a couple of patients that come to see you in clinic, and they're both big guys. One is knock-kneed and the other is bow-legged. So how does this system come to use? How does it help us? Well, we always start by getting the long x-ray, patella forward, showing hip, knee, and ankle on the same cassette, and draw the line from the hip to the ankle. That's the mechanical axis of the entire limb. And the first thing you want to do is just describe how far that is from the center of the knee. And that distance we call the mechanical axis deviation. It's you measure how far the line is from the center of the knee. How far off from normal are you? And in this case, it's way off. It's outside the knee, so it's probably about 40, 50 millimeters off. Our other friend here has got the opposite problem. He's got a bow leg problem. And when you draw his mechanical axis from the center of the hip to the center of the ankle, he's medial to the knee instead of the other guy who's lateral to the knee. So this is how we define varus and valgus. The the knock-knee person who's in valgus has mechanical axis lateral. The bow-legged person has a mechanical axis line that falls medial to the center of the knee. And you can quantify these by measuring the distance in millimeters. Pretty easy, right? I mean, it's pretty straightforward. When we start to look at kids and adults with deformities, there are 4 potential sites of deformity in the lower extremity. You can have a femur deformity. You can have a tibial deformity, like that last Blount's boy. You can have knee joint laxity that's opening up. The tibia and femur could be totally normal in measurements and lines, but you have laxity in the joint line. And lastly, you can have intra-articular deficiency. If you've had, say, a tibial plateau fracture and it crushes down, that can give you a varus. So you kind of have to look at that also. Has there been an injury? Has there been a developmental problem, a growth arrest that's caused an intra-articular incongruity? And that's about it. Those are the 4 reasons why people have a malaligned leg. So the quick test that we do when the patient comes in the office is called the malalignment test. And we're going to do more than that. We'll do malalignment and malorientation. We start by drawing a line from the center of the hip to the center of the ankle, and we simply look to see where does that line fall. If that line falls lateral, then we say you are valgus. If that line falls medial, then we say you are varus. If that line falls right in the center of the knee or pretty close to it, then we say you're okay. So it's a quick screening test. You get the x-ray, because sometimes it's not obvious, especially with really heavy people nowadays. We see so many heavy kids, for example. Sometimes they look like they're in valgus. They come into the office and they're standing like this. And they say, my God, you must be valgus. But it turns out the reason they're standing like this is because they have so much fat in their thighs that they can't bring their legs together to stand underneath them. So they walk in like this. We call it the fat thigh gait. They walk in. They don't put one leg in front of the other. Like most people put one leg in front, exaggerating, put one leg in front of the other. But these kids will walk into your office, with one leg just progressing. So, and you get an x-ray, and they're perfect. Their hip, knee, and ankle fall in a straight line. They're just walking so far apart, and they look like they're in valgus because of the excess of tissue between the thighs. So I've been fooled, and a lot of kids who I look at say, you must be bow-legged or you must be knock-kneed when I get the x-ray. They're not. The other thing that I get fooled on is the club foot patients. They look like they're a little bit bow-legged, but it turns out they don't have the normal sort of medial gastroc. And so when you look at their leg, it looks a little funny. It looks like it's off axis, but you get the x-ray and they're perfect. Okay, so this is the malalignment test. It's simple. It takes you 2 seconds. Just on any PAX, you just draw a line from the hip to the ankle. Or if you're using, is everyone using PAX, or who's not using a PAX? Who uses a film? Nobody? Oh, okay. It must be a baby boomer. Gen X and Gen Y, you guys are all into PAX, right? Is anyone here born before 1962? Okay. So if you're born before 1962, you're a baby boomer. If you're born between 1962 and 1980, you're a Gen X. And those of you who are born, who's born after 1980? Gen Y. Okay, so you guys are totally into the technology. Anyway, we used to draw these with a crayon on a long film, but now everything is on a PAX, so you just draw it. It's very easy. So here's the big boy, or another big boy, that comes in the office with Blount's disease. And there's his x-ray and a close-up of the knee. How do we do this? So the whole test, I'm going to take you through the malalignment and malorientation tests. So we start, it's easy, draw the MAD. Draw a line from the center of the head to the center of the ankle. And then you're going to measure that distance. How far does it come out from the knee joint? It's clearly in varus. The next step is we want to determine, all right, so you're a genius. You've said he's bow-legged. I didn't need to do a malalignment test to figure that out. I could tell that. But now the next test is to try to determine where is the bow-leggedness coming from? Where is the varus? What's the source? Is it femur, tibia, both, or neither? Is it maybe the joint, or all 3? So that's where we start to draw on all the other lines I've been talking about. So we start by drawing the mechanical axis of the individual bones. The mechanical axis of the femur is from the head to the knee. Now we draw the joint orientation line of the knee, right, from the tip of the femoral condyles. What's the normal lateral distal femoral angle? 87. Should be between 85 and 90, and this one is way off. This one, when we look at it, it's 99 degrees. Okay, so it's clearly beyond 90 degrees. So this is one source of the varus. Now, maybe it's the tibia too. We've got to look at the tibia. So the next step is to analyze the tibia. So we draw a line from the center of the knee to the center of the ankle. That's the mechanical axis line of the tibia. And then we draw the joint orientation line of the tibia, which is along the top of the tibial plateaus, and measure the medial proximal tibial angle. And what's normal? Right, 87. And this guy measures 75. 75 isn't even close to normal. If you say 87 is normal, but there's a range, right, 85 to 90, 75 isn't even close. So just like my dog can have ticks and fleas while he's itching, so this guy can have a femur and a tibia contributing to his varus. It's not just one bone. And so the importance of doing the malorientation, malalignment test is so that you can determine which bone is going to be operated on. You have to pick the bone for surgery. So which bone are we going to pick? Or maybe we should pick two, or pick both. We can talk about that, and I think subsequent speakers are going to talk about how they decide which bone to operate. But this test tells you where the problem is. But we're not quite done. We said, all right, we got a femur problem. We got LDFA of 99, that's bad. MPT of 75, that's bad. What else do we have? Well, last step is look at the joint lateral convergence angle, the joint line convergence angle, and measure that. Those lines are normally pretty parallel, maybe within 2 degrees of parallel. But this kid, this big kid, had been walking on it, and because he's bow-legged and walking on it as a heavy kid, he's attenuated and stretched out his lateral collateral ligament. And so he has a joint line convergence angle of 10 degrees. So when we look at the totality of what's contributing to this massive varus, this massive bow-leg deformity, it's coming from a femur problem, a tibia problem, and a joint laxity problem. And so we have to decide as surgeons, what are we going to address? Are we going to just do a tibial osteotomy? Are we going to do just a femoral, do both? Should we do something to deal with the ligaments also? And so we don't see any intra-articular deficiency. There's no depressed medial plateau here. And last but not least, we should look at the hip and ankle orientation. We focus on the knee, but we also want to measure the joint orientation lines at the top and bottom and make sure there isn't a secondary deformity. So this kid, we conclude, has 12 degrees of varus in the femur, 12 degrees of varus. And these are just how far off from normal. So 99 minus 12 is 87, and 75 plus 12 is about 87. And he also has, if we said that a normal JLCA is 2 degrees, then he's got at least 8 degrees coming from the soft tissue. So he's got some real problems, and he needs some work. Now, all this is based assuming that you're getting the proper x-ray. Because if you don't get a proper x-ray oriented with the patella forward, if the knee isn't straight, then all bets are off. If a patient comes into you with a knee flexion contracture of 35 degrees, you get this x-ray, you're not going to be able to measure the angles. So in that case, you're going to have to take a separate x-ray of the femur and another separate x-ray of the tibia square on to measure it. And by the way, the way to do that with a knee contracture is put him prone. If you put him prone, then you get a PA film of the femur, and then you get a PA film of the tibia. Because you want to get your cassette perpendicular to, and your beam perpendicular to the knee joint. So the other thing you have to worry about is magnification. So to get everything on, you have to have your x-ray beam coming from about 10 feet away. And we've calculated that in our setup we have about 4% magnification, but now our radiology techs are trained to put a mag marker on every x-ray they take. We have a 1-inch steel ball. So this one doesn't have it. It's an old film. But that's our setup in the clinic. You want the x-ray to be made focused on the knee. Now when you do this, you do get some parallax issues involving the ankle and the hip. I mean, you're getting a true AP of the knee, and you can measure these angles. But if you're talking about, if the patient's primary problem is an ankle problem, if they have a malunited ankle fracture, then I wouldn't get all my measurements off of this film. I would get a true AP of the ankle, centering on the ankle. So you have to be practical. This is a good overall screening test, but if you're dealing with a hip problem, you want to take an AP x-ray of the hip. If you're dealing with an ankle problem, you want an AP of the ankle. But if you're looking at the totality of the limb, this is what you need to do. And the same thing on the sagittal view. And you ask the tech to make sure that they keep their knee straight, because we're trying to look for subtle knee flexion contractures or hyperextension. So the patient has to be told to give maximum extension of the knee when they do this x-ray. I'm not sure this is going to work. Let's try this. Oh, okay, no. Well, this is a very, very abbreviated version of what we do over a course of 3 days at a course we run every year based on these principles. And I would invite any of you who wants to invest a little more time and energy. We actually have one coming up August 30th to September 2nd. I'll be happy to see you there. So thank you very much for your attention.